If you look at early man, our hunter-gatherers, the biggest threat was undernutrition. You know, we needed to have something to protect us as in the hunter-gatherer populations for times of famine, because one of the biggest threats was starvation, and that was adipose tissue. Adipose tissue was really essential for survival, and if we didn't have it, we would never have survived the millenniums. So clearly, modern man today suffers from diseases of overnutrition. And the very tissue that allowed us to survive as a species is now killing us. And so here is adipose tissue, and what is it? It's a collection of adipocytes surrounded by a loose connective tissue and a stromal vascular fraction. Well, what is that? That's pre-adipocytes, which I'm going to be talking about, fibroblasts, endothelial cells, and immune cells. And the term adiposity has to do with excessive adipose tissue with the manifestations of overweight and obesity. One of the things I'm going to be focusing on today is the term adiposopathy, or sick fat, which really is defined as dysfunctional fat, which is promoted by positive caloric balance, physical inactivity, especially in genetically susceptible individuals, and I'm going to discuss that today. But it results in an adverse endocrine immune response that increases not only cardiometabolic risk, but promotes cardiovascular disease. Well, where does most of our fat, where is most of the adipose tissue located? The overwhelming majority, about 80%, is in subcutaneous adipose tissue, subcutaneous fat, whereas about 20% is intraperitoneal, visceral fat. And one of the themes I'm going to develop is that visceral fat, as it turns out, is more metabolically active than subcutaneous fat and more likely to become dysfunctional. And you know, as a result, it's important when we talk about adiposopathy to understand how it works. And here it is. So pay attention. I'm going to take you through how we develop sick fat or adiposopathy. And it all starts with a flawed lifestyle. We have positive caloric balance, physical inactivity, and this really leads to the adipocyte increasing in size, what's called adipocyte hypertrophy. Well, that leads to intraorganelle stress, and especially in the endoplasmic reticulum. And the normal response is for pre-adipocytes to come onto the scene. We recruitment and differentiation, and they become adipocytes to be able to handle the increasing caloric load, to be able to maintain normal adipocyte function. But in those individuals today that have an overwhelming caloric intake, the adipocyte becomes insulin resistant because of the intraorganelle stress. And when that happens, remember what happens in insulin resistance, we're taking the brake off of lipolysis. We no longer inhibit hormone-sensitive lipase. So we get lipolysis, and we get mobilization of free fatty acids. And the free fatty acids will increase visceral adiposity, but it'll also go throughout the body. And we get what we call lipotoxicity. Our body, other organs, non-adipose tissue organs, do not like free fatty acids because it damages the tissue. And we'll discuss that. But clearly, if free fatty acids end up in the heart, we can get myocardial steatosis, contributing to heart failure. In the pancreas, beta cell dysfunction, contributing to the development of type 2 diabetes, liver, fatty liver, and so on. So I am now going to show you, I'm going to do a little video look at this process. So here's the normal individual. The normal individual with normal adipocyte function. We're going to see triglycerides coming in. It really comes in as free fatty acids and is repackaged as triglycerides within the adipocyte. But as we get increasing load of fat in the form of triglycerides, which is the storage form, we get recruitment of pre-adipocytes. They come in and they pick up the load so that these adipocytes never undergo adipocyte hypertrophy. And although the individual may gain weight because of the adipogenesis or adding new adipocytes, you won't get adipocyte dysfunction. And that's critical. Now contrast that to the patient who has dysfunctional fat. Here we see, again, we see an adipocyte. We see the fat load coming in, and that leads to adipocyte hypertrophy. But in this case, in a genetically susceptible individual or an overwhelming caloric intake, we get lipolysis. So the free fatty acids will leave the adipocyte, they'll hitch a ride on albumin, and then we're off to the races. You know, again, it goes to other tissues and leads to lipotoxicity. That's it. And it's important that you understand these mechanisms. So here you could see an example of, you know, the free fatty acids going to skeletal muscle, and that can lead to skeletal muscle insulin resistance. When the free fatty acids, as I said, can damage the beta cells in the pancreas, leading to type 2 diabetes, and of course in the liver we get fatty liver, we get hepatic insulin resistance. So one of the things that's important to understand is that weight gain leading to metabolic disease is most dependent upon, first and foremost, how fat is stored. So, you know, are we dealing with adipocyte proliferation, which is the normal functional approach? Or do we have adipocyte hypertrophy and intraorganelle stress on the endoplasmic reticulum and a loss of adipogenesis and lipotoxicity? Secondly, the question is, where is the fat stored? Is it stored in the subcutaneous tissues, which is the normal healthy response, or is it stored in the visceral adipose tissue, which is, again, more metabolically active, more likely to become dysfunctional, more likely to kick off inflammatory adipokines, which I'm going to be talking about. And finally, the question also is whether a patient develops cardiometabolic disease, what's the health of their organs? So free fatty acids, for instance, that go to the liver, you're less likely to develop metabolic derangements if you have a healthy liver. Somebody who's an alcoholic who has cirrhosis of the liver doesn't have that reserve, and then therefore it exacerbates this process. The other thing which is fascinating, for the longest time we felt that atherogenesis, of which I have a long-standing interest in, was just too many ApoB lipoproteins crashing the artery wall and kicking off the atherosclerotic disease process. We now know that part of lipotoxicity with these free fatty acids can get into the arterial wall, and we get perivascular fat, and that kicks off vascular inflammation, endothelial dysfunction, upregulation of adhesion molecules, and again, this is a different pathway to atherosclerosis, the so-called outside to inside theory of atherogenesis that has been well chronicled in the literature. For diabetes, as I've discussed, you know, clearly adiposopathy, as I showed you, increases circulating free fatty acids, and it could lead to insulin resistance in the liver and muscle, and it could also damage the pancreas, leading to the development of type 2 diabetes. Well, in addition to that, when we have adiposopathy, we get increased free fatty acids going to the liver, so the liver pumps out more triglyceride-rich VLDL particles. And these particles will interact with LDL cholesterol, with cholesterol ester transfer protein, and we get a swapping of triglycerides from the triglyceride-rich VLDL particles to LDL cholesterol, which then is acted upon by hepatic lipase. The triglycerides are hydrolyzed, and we end up with numerous small, dense, more atherogenic LDL particles. The same thing can happen with HDL, the same swapping, and we can end up with small, dense, less functional HDL. And I think that contributes also to the problem, as well as the adipocyte. And the dysfunctional adipocyte can release angiotensinogen, and therefore increasing our blood pressure. So if you look at it, all of these mechanisms will increase the likelihood of atherosclerosis and an atherosclerotic plaque. Now, one of the things I'm going to discuss is the adipokines, because remember, when fat becomes dysfunctional, it starts releasing, especially visceral fat, adipokines that are pro-atherogenic. The first one is leptin, and leptin, everybody knows, is the satiety hormone. It goes to the brain, the hypothalamus. It tells us we're full after we eat a meal. And certainly what we understand is that when we get obese, we get increased leptin levels due to leptin resistance. And leptin, the peripheral actions of leptin, increase the likelihood of metabolic syndrome. We also have pro-thrombotic adipokines like PI1. We have pro-inflammatory adipokines, TNF-alpha, interleukin-6. We have monocyte chemotactic protein, which facilitates monocyte entry into the subendothelial space in the vascular wall, which is instrumental in an atherosclerotic disease process. They become macrophages and engulf oxidized lipoproteins. And then we have adiponectin. And it's important that you understand adiponectin because that is the anti-atherogenic adipokine. And we understand the importance of adiponectin, which mainly is released by the subcutaneous adipocytes. That's why I say the subcutaneous adipocytes are certainly better than the visceral adipocytes, which have less adipokine release. And we understand that adiponectin really lowers inflammation, lowers the risk of metabolic syndrome right on down the line. We could have an entire morning symposium just on the adipokines and how they impact things. Just a couple of quick notes. Leptin, one of the major ways that leptin is harmful is it impairs insulin signaling in the adipocyte, contributing to insulin resistance and, of course, increasing free fatty acid release. Here's an article that shows that elevated leptin levels can increase the risk of developing metabolic syndrome. Adiponectin, which I talked about, low adiponectin levels may reflect dysfunction of adipose tissue. So one of the first things we see in adiposopathy is declining adiponectin levels. We also see development of fatty liver. And because the question is, how do we make that diagnosis of adiposopathy? Well, those patients who develop cardiometabolic risk, they have low adiponectin levels, they have fatty liver, they have increased the atherosclerotic triad of high triglycerides, low HDL, too many small dense particles. This was a very interesting study that looked at men with low adiponectin levels, and they had a 200% increase in their risk of developing coronary artery disease. So it's important and certainly can be used as a biological marker to assess risk and to monitor treatment. So the question is, how do we increase adiponectin levels? Well, first and foremost, lifestyle. A healthy diet, along with physical exercise that causes weight loss, will significantly raise your adiponectin levels. The single best way of doing it. Certain nutraceuticals can also do it, like omega-3 fatty acids, along with some pharmaceutical drugs, such as the statins, the TZDs, metformin, and others. All right, now I'm going to discuss something really interesting, the obesity paradox. And what is the obesity paradox? Well, we understand that not all overweight patients develop metabolic disease, and not all patients with metabolic disease are overweight. And why is that? Well, this becomes less paradoxical if we understand that adipocyte function is more important than adipocyte mass. So in other words, whether your adipocytes are functioning normally, which is reflected more by waist circumference measurements, is more important than adipocyte mass, which is reflected by body weight or BMI. Now, clearly, at the extreme levels of BMI, that's a whole different situation where we understand that there's other problems that can develop. But this is very critical to our understanding. So at the end of the day, adipocyte function trumps adipocyte mass. So let's go over some of these paradoxes. Let's start with the ethnic obesity paradox. We know that Asians, and in particular Southern Asian Indians, are much more likely to develop cardiometabolic disease with type 2 diabetes and cardiovascular disease, even though they're not overweight. Most of them are, by our standards, normal body weight. Why is that? Because they're genetically predisposed to to a loss of adipogenesis. They don't have the ability to have adipogenesis and maintain normal adipocyte function. So despite the fact they're not overweight, they still develop lipotoxicity, mobilization of free fatty acids. And as a result, this paradoxical situation is really not paradoxical. It's what we would expect with somebody who, for genetic susceptibility, is unable to have adequate adipogenesis to handle caloric load. And by the way, they also have, if you look at them, not only increasing inflammatory markers like C-reactive protein, but also decreased adiponectin levels. How about the gender obesity paradox? Well, the question is, why do women who have twice as much fat, body fat, as men, why are they somewhat protected? You would think they'd have a higher risk of cardiovascular disease than men because of the increased fat. Well, women tend to be pear-shaped. They have a gynoid or gluteofemoral subcutaneous fat pattern compared to men, which is more of the android, central obesity, visceral adiposity pattern. And as a result, we understand that subcutaneous fat in the gluteofemoral regions is not detrimental. If anything, it can actually be helpful to preventing metabolic disease versus the more metabolically active visceral fat. Now, interestingly, when women reach menopause, and declining estrogen levels, there's actually a movement of fat to women become more like the male pattern, and fat moves to more of a visceral rather than a subcutaneous gluteofemoral pattern. And of course, as we all know, women, when they hit menopause, catch up to men very quickly as far as their risk of cardiometabolic disease. The physiologic obesity paradox. When does fat mass accumulation actually be helpful to lower cardiometabolic risk? Well, an example is benign multiple symmetrical lipomatosis. This is a disease where people gain fat in the subcutaneous tissue. And we've known for years that these individuals, despite the fat gain, are protected. They have a very low incidence of developing cardiometabolic disease because they have functioning adipocytes that are there to protect them. And that is in contrast to those individuals with lipodystrophy. Now, you can have an inherited or acquired lipodystrophy. These are individuals who are thin. You would think they're thin, they'd have a very low incidence of adiposopathy and cardiometabolic disease. The problem is they don't have adequate storage for fat. And because of this, they have limited fat storage. They have high circulating free fatty acids that contribute not only to lipotoxicity, but to metabolic disease. There's also the therapeutic obesity paradox. PPAR agonists, the TZDs like pioglitazone. We've known for years that these drugs cause patients to gain weight. Why do they cause patients to gain weight? Because they improve adipogenesis in individuals that are at increased risk for cardiometabolic disease. So that's not a bad thing, People don't like weight gain, but actually that's how they work. And so they improve the subcutaneous to visceral adipose tissue ratio and thereby lower glucose levels and improve cardiometabolic risk. Contrast that to the opposite, a drug that actually causes weight loss, and that's in HIV patients taking retrovirals. Those individuals lose functional subcutaneous adipose tissue, and they increase their risk of cardiometabolic disease and cardiovascular disease. This is really fascinating, and that is the acute coronary syndrome paradox, where we see individuals with acute syndromes, acute myocardial infarction, actually have a better outlook if they are mildly overweight than people who are normal body weight. Well, how can that be? Well, it can be partly explained by looking at the lineage, because we understand that adipocytes and cardiomyocytes share the same lineage from mesoderm and mesenchymal cells. And so what we see is that in the setting of an acute event, individuals who are overweight or obese have greater mobilization of the progenitor cells in the circulation compared with thinner patients. Therefore, after somebody has an acute event, the greater availability of these progenitor cells that can go to sites of injured myocardium afford greater cardiovascular self-repair and improved outcomes. Fascinating topic, fascinating area. So what do we do about it? Well, first and foremost, we want patients to lose weight. And we want them to lose weight in a healthy. You can't take a patient and have them lose weight by having them eat highly processed food and expect that to improve their cardiometabolic risk. But there is one dietary pattern that has been around for thousands of years. That's the Mediterranean diet. And that has the most scientific evidence as far as improving adipocyte function and lowering cardiometabolic risk. One of the landmark papers was by Esposito and colleagues, published in 2004. And this showed the Mediterranean diet resulted in a significant reduction in body weight, insulin resistance, blood glucose, inflammatory markers, and blood pressure, with significant improvement in the lipid profile, and 50% significant decrease in those individuals entering the study with metabolic syndrome. They no longer had metabolic syndrome after 1 year. Really, it was a landmark study, and it heralded in a lot of other studies that looked at the Mediterranean diet and improvement of metabolic syndrome, and specifically an improvement of adipocyte function. Now, this study also is interesting. It was by Sophie and colleagues that looked at fatty liver, non-alcoholic fatty liver disease, and concluded that among all the diets that have been proposed, the Mediterranean diet was the most effective dietary option for inducing weight loss, together with a beneficial effect on non-alcoholic fatty liver disease. Certainly the Mediterranean diet is rich in omega-3 fatty acids, and we know that the omega-3 fatty acids can actually attenuate adipocyte, adipose tissue inflammation and improve adipocyte function, and that has been shown in numerous studies in the literature. Also, this study which showed the Mediterranean diet as very effective in improving adipocyte function. So again, it's lifestyle intervention that becomes most critical, and especially with those nutritional patterns that are associated with improvement of adipocyte function and a lowering of cardiometabolic risk. But remember, it's the Mediterranean diet and lifestyle. So that lifestyle means that people in the Mediterranean regions of the world that follow a traditional Mediterranean diet and lifestyle, they get a lot of physical activity. And certainly I'm not going to be talking about this because the next speaker to follow me is our keynote speaker, Peter Kaczmarzyk. And this is from one of his studies that showed that even if you have metabolic syndrome, if you are physically fit, you have a better outcome, all-cause mortality, than an individual who does not have metabolic syndrome but is unfit. Well, the take-home point is that we need to avoid the being at low fitness. So regular aerobic activity on a daily basis is really one of the prescriptions that should be prescribed to all our patients. So in conclusion, number one, adiposopathy or sick fat leads to increased cardiometabolic risk. And understanding the difference between adiposity and adiposopathy helps to explain the obesity paradox in a variety of clinical settings. And finally, appropriate treatment of adiposopathy lowers the risk of metabolic syndrome, diabetes, and cardiovascular disease. Thank you very much.